Good morning, everyone. I'm Craig Brad. I'm presenting this morning on tunnel widening in revision ACL reconstruction, which was a review article in the American Academy of Orthopaedic Surgeons last year by Travis Mack et al. From New York, and also another author from Kansas City. Two of the authors received royalties for and that they admitted to in the paper. So what are the causes of ACL reconstruction failure? Well, they're split into sort of four main classifications: mechanical, biological, new trauma, and a missed secondary stabilizer injury. So the mechanical problems can be a non-anatomic tunnel, an inadequate notchplasty, inappropriate graft tension, graft fixation failure, or paucity graft material. The biological problems can be failed ligamentization of the graft, infection, arthrovibrosis, and infrapatellar contractions. And if you miss a secondary stabilizer injury, you might have missed a rotatory instability, a severe malalignment of the limb, or a varus or valgus instability that should have been corrected prior at the time of ACL reconstruction. So 10 to 15% of primary ACL reconstructions fail, and 20% of revisions fail. And tunnel malposition is the commonest cause of early failure, so it's a surgical error, especially on the femoral side. And the common problems are due to the associated osteolysis and poor graft fixation. And this can cause delayed soft tissue graft to bone incorporation and reduce the graft stability. You also get tunnel widening after an ACL reconstruction, and the cause is really unknown. It's thought to involve mechanical and biological factors, and it can occur early or late. And if it occurs late, it can be asymptomatic or it can be symptomatic as the graft has failed. So this is a sort of diagram of what causes, they think, tunnel widening. Mechanical factors, the main two are graft position and the type of fixation that you used. And the biological factors are the type of graft, whether it's bone patella bone, bone patella tendon bone, or hamstring. What sort of donor graft that you use, whether it was autograft or allograft, whether there was any synovial fluid propagation, and what implant material and preparation that you used. The biological factors are linked with a local biological response with an inflammatory reaction and increased cytokine levels that cause osteolysis and tunnel widening, whereas the mechanical factors generally tend to cause a mechanical graft tunnel abrasion, and that weakens the graft over time. There are four sort of tunnel types that are associated with widening. Fairly simple: linear, cavitatory, so there's a cavity here, a mushroom type canal, and a conical type. So when planning a revision ACL reconstruction, the keys to successful outcome are to select your patients, make sure that as much as possible they're going to comply with the rehab protocol that you're going to instigate, and realize that they've got achievable goals and that are realistic. Timing is very crucial when you do the operation to ensure that you've got as much in your favor. And make sure that you're doing it in the correct patient, so whether they're athletic and whether you've corrected any secondary stabilizer injury as well. Select the graft that's most appropriate, and that's going to be looking at the primary ACL reconstruction. What you've already used before will influence what you can use later. And look at the intraoperative factors that you can control, so your tunnels, your positioning, and your debridement of the tunnels. Secure fixation and the tensioning of the graft, and obviously the post-operative rehabilitation is key. So the theory of tunnel widening, the mechanical theory is graft motion within the tunnel may abrade the tunnel edge, and that might lead to widening. And as I've said before, there's two main problems: the graft position and the fixation method. So poor graft position leads to tunnel widening. Anterior tibial tunnel placement causes impingement of the knee and extension, and that causes increased graft forces at the graft tunnel interface, which in turn causes osteolysis and subsequent graft failure. A horizontal femoral tunnel will increase the mechanical stress at the anterior aspect of the femoral tunnel and cause widening. And the location of the bone block, especially in bone patella tendon bone grafts, are associated with increased tibial tunnel widening, but not with femoral tunnel widening. And if you put your interference screw fixation and overlap the tibial bone plug on the attached talar tendon, that significantly reduces your tibial tunnel widening. There is a correlation between the increased distance from the point of your graft fixation and the increase in longitudinal and transverse tunnel motion. So if you have an increased length between fixation points, that will decrease the stiffness of the graft, increase the displacement in the graft between cyclic displacement, and reduce your knee stability. Also increased micromotion at the intra-articular aperture compared to the mid-tunnel and the tunnel exit, especially in full flexion, is due to reduced bone tendon ingrowth. And that increased aperture osteoclastic activity will result in osteolysis. The two main sort of types of fixation methods: suspensory fixation, which occurs via fibrous tendon bone healing, and aperture fixation by direct contact bone healing. Supplemental aperture fixation with interference screws or bone plug, or versus suspensory fixation alone, was studied by Schultz et al. In a paper, and he found increased tunnel widening in the supplemental aperture group. Whereas Fauner and Calhoun compared suspensory fixation versus aperture fixation, and they found increased tunnel widening on the tibial and the femoral side in both groups. And there was a trend towards knee laxity, but it wasn't clinically, didn't affect the clinical outcomes. So suspensory fixation via the endo button was described in the paper. And there's two problems. With suspensory fixation, you get the bungee cord effect with longitudinal motion from elongation and retraction of the graft in the tunnel that can cause tunnel widening. Whereas in interference screw fixation or aperture fixation, you also get the windshield wiper effect, where you get oscillation of the graft in the tunnel that can abrade the graft at the tunnel entrance and cause an influx of synovial fluid, which is more common on the tibial side than on the femoral side. So Bulow and all looked at 60 patients with quadruple hamstring autograft ACLs, and there was two groups: anatomic fixation with absorbable screws, and the femoral endo button or tibial non-absorbable sutures tied over a washer on the tibia. In the immediate post-op group, 75% increase in femoral and tibial tunnels, that's widening. And at 6 months, 31% increase, but between 6 and 24 months, no additional increase. That's in the anatomic fixation group. In the femoral endo button group, there was no immediate tunnel widening, but at 6 months, there was a 65% increase in widening. But however, at 2 years, the 2 years, there was no significant difference between the two fixation types in terms of clinical outcomes or graft rupture. Biological factors, there's 5 main ones that have been deemed important: how you sterilize a graft and what the cytokine level is, the implant material, the type of graft you use, the donor graft that you use, and whether there's synovial fluid propagation. There's an inflammatory state, and the elevated cytokine levels have been associated with an acute ACL rupture at 3 months. And prolonged elevation of these can cause osteolysis or chondrolysis via activation of osteoclastic activity. That can be the inflammatory process can be further propagated by graft and bone necrosis from drilling. And elevated interleukin 6, 8, and tumor necrosis alpha have been indicated after any ACL rupture. The method of sterilization of the graft, there's no causal relationship with tunnel widening, but ethylene oxide sterilization has caused significant intra-articular reactions and impaired healing of the graft. So what type of material that you implant? Mozella et al. Did a MRI study of autologous hamstring ACLs and found there was a correlation between tunnel widening and the type of graft that he used, and they found that femoral tunnel widened with bioabsorbable screws over metal screws. However, again, there was no difference in outcome scores or knee laxity. In terms of graft failure, there's an increased risk of failure of the graft with bioabsorbable screws, which was around 23%, over metal screws, which was 6%, and that was clinically significant. There's also increased tunnel widening with bioabsorbable screws when there was PLLA and hydroxyapatite, rather than just polylactic L-acid alone. Insalata et al. Did a study in 1997 looking at the type of graft, bone patella tendon bone versus hamstrings, and found that the hamstring group had almost double the rate of tunnel widening than bone patella bone, and concluded that mechanical factors were the cause of the widening. A further study by Clatworthy et al. Did a prospective study of 73 patients, again comparing bone patella tendon bone and hamstrings, and also found that the hamstring group had increased femoral tunnel widening, and found that the bone patella tendon bone group actually had reduced widening of about 25%. And there was increased tibial tunnel widening in the hamstring group as well, which was significant. And again, the bone patella tendon bone group decreased. That was all at 4 months, those findings. However, there was no progression in either group at 6 and 12 months. The graft donor types, increased tunnel widening has been associated with fresh, frozen, non-irradiated bone patella tendon bone grafts over autografts, as you'd expect. And Achilles tendon graft had similar results as hamstring graft, and there was no widening documented after 2 years. That was in a paper looking at those two. Synovial fluid propagation in animal studies show that synovial fluid influx alone isn't enough to cause tunnel widening itself, and this synovial fluid influx may delay bone healing, especially at the intra-articular entrance of the femoral tunnel. So radiographic assessment is really important for evaluating preoperative planning in revision ACL, and plain X-ray, CT and MRI can be of use. You really want to look at the tunnels, the size and location of the tunnels, the soft tissues, the articular cartilage, hardware positioning, and the incorporation of any soft tissue graft or bone plug in the native bone. So the standard X-ray is a standard AP, 45 degrees of flexion, PA, and a lateral weight bearing view and extension. To assess the tibial tunnels is best on the AP radiographs, and the tibial tunnel best on the lateral. And how you assess the tunnels, there's two methods that are described in the literature. There's the Laxdal method and the Clatworthy method. The Laxdal method measures 3 points within the tunnel and averages 3. The Clatworthy method measures the percentage tunnel widening on the initial X-rays and subsequent follow-up X-ray. And if that increases by more than 50%, they diagnose that as tunnel widening. That's an example of tunnel widening in the tibia, best seen in the lateral radiograph. So CT scans can also be used with coronal, sagittal, and axial reformats to look at the bony architecture, the position and the size of the tunnels, the cross-sectional area, and any bony sclerosis around the tunnels, as well as looking at bony ingrowth. However, the MRI is seen as the gold standard currently, and it's excellent for assessing the tunnel size, any bony and bioabsorbable screw fixation, whether it's been incorporated, the integrity of the ACL graft, looking at the menisci and the articular cartilage, as well as the cross-sectional area. Prophylactic strategies to reduce tunnel widening. They tried in some papers to use a periosteal flap from the anterior tibia and wrap it around the proximal hamstring graft and secure it with an intraosseous fixation with an Arthrex transfixed screw. And they found that was a significant reduction in femoral tunnel widening. However, it was a very small paper and just one of its type. They also tried compaction of autograft bone into the tibial tunnel. Has also been shown to reduce tunnel widening. And these mixed bioabsorbable screws may reduce widening, but metallic screws may be better. Now, they don't mention the paper that was from, and there's no reference for that. It's just from the authors. Looking at the clinical outcomes, which is really what we're interested in, at the end of the day, no correlation has been found between radiographic tunnel widening and the clinical outcome, and that's from 2 quite large papers on the subject. Bioabsorbable and metallic interference screw fixation on MRI was looked at by Mozella et al., and there was a direct correlation in both groups with increased tunnel widening and knee laxity. This is a treatment algorithm that they suggest to use for revision ACL reconstruction with tunnel widening. And on your radiographs, you have to split the groups into 2, whether you're going to go for whether the tunnel is currently anatomic or whether it's not anatomic. And you've got to assess the percentage widening and the bone quality. The graft selection I've mentioned before, it's important to know what type of graft was used before. But with widened tunnels, it might be difficult to use hamstring autograft or allograft because of the resultant increased risk of tunnel widening and the poor bone stock. And that's the advantage of the bone patella tendon bone autograft. And you can use a bone plug to fashion it with that to the deficit in the tunnel. The commonest revision graft, according to the author of the paper, is the bone patella tendon bone autograft. If the tendo-Achilles allograft has been used in the primary, which seemed to be in vogue with the author. So your options for managing tunnel widening are to use a divergent technique, and that works on the principle of a bony bridge between the 2 tunnels. So this is the original tunnel, and you're trying to create a divergent tunnel there. Stacked interference screws, so if you've already got screw fixation, you stack it in again prior to your aperture fixation. Or you do what's called matchstick or bullet bone grafting and cortical allograft. So you pack the tunnel first, so there's little matchstick pieces of bone up there. Or you use a large bone plug as another option. Or if that fails, you can do primary bone grafting and then a stage reconstruction. So you do bone grafting first, then come back 3 months later, and then do your second stage. These are just a few photos. There's your bone plug that you're using, and then your bone plug. Primary bone grafting and stage reconstructions are indicated when there's over 100% tunnel widening or 15 to 20 millimeters in any dimension on imaging, or an isometric anatomical graft isn't possible. So the principle is you prepare your tunnel well, remove all your fibrous tissue and sclerotic bone, and you pack it with morselized iliac crest autografts, which would be ideal, or allograft bone chips. They have looked at demineralized bone matrix and calcium phosphate injection into the widened tunnels with some success, but these are very provisional papers and it's not widely used and there's not much literature on it. The principle is to remove all the hardware as well at that stage and then consider revision reconstruction at 3 to 4 months. This is how you do it. You basically remove all your hardware, you pack it up with graft, and then put your tunnels in. That's just an example of. In summary, there's considerable debate regarding what actually causes tunnel widening in revision ACLs, whether it's mechanical or biological. And however, there's some quite a body of evidence to suggest that even with tunnel widening, it might not actually be clinically significant to affect the outcomes.